Hello, everyone. I'm Hartford HealthCare's Tina Verona. We are coming to you live from the Pink Party here in Blueback Square in West Hartford, set to kick off today at 5 o'clock. And really, this event is all about raising awareness and celebrating survivors of breast cancer. I am so happy to be joined by Dr. Alvaro Menendez, a hematologist and medical oncologist specializing in breast cancers. Thank you so much for being here and welcome to the Pink Party.
Thank you for having me, Tina. I'm excited.
Absolutely. Well, you specialize also in minority oncology. How is it that minorities are impacted by breast cancer?
Yeah, that's one of the big things that Hartford HealthCare Cancer Institute is doing, raising awareness not only about breast cancer, but also breast cancer in minorities. Breast cancer, I think everybody knows, is the most commonly diagnosed cancer in women, and minorities, Hispanics, for instance, are not the exception. Breast cancer is the number one most common cancer diagnosed in Hispanic women. And unfortunately, and this is based on clinical studies that have shown that minorities are at a higher risk of not going to the doctor, not getting their screening mammograms, not getting their screening tests on time, and not really having close follow-up if there's abnormal results that are noted. Unfortunately, breast cancer is diagnosed at later stages in these populations, and therefore it still represents, unfortunately, the most common cause of cancer-related death in this population. One of the big things also that we're trying to raise awareness is breast cancer does not only affect women.
Right.
1% of all breast cancers is that are diagnosed with breast cancer are men.
Yeah,
And
I
so,
actually think, I just read the other day, Beyonce's father was diagnosed with breast cancer.
yes, exactly, and that's important to bring up, because a lot of the times men, especially those in minority populations, and sometimes those that are not minorities, will tend to think, oh, that's just a disease that affects women, but it's not, unfortunately.
Right. Now, you mentioned among minorities and the Hispanic population that don't go and get screened, that don't go and have mammograms. We actually spent some time today with Karen Weingrod, the director of the breast program, and she is out and about, not just this month during Breast Cancer Awareness Month, but all year with Hartford Hospital's mobile mammography coach. And it's all about access. They're literally going out into the community, providing that access, and then also with the nurse navigators, following up with that care so that these women, and since its inception, 20,000 women have come through that coach.
Yeah. Oh, Karen and the team at Hartford HealthCare Cancer Institute are fantastic. That's one of the big things about this. When we start talking about why is it that women, whether it's minorities or non-minorities, are not getting screened, you start talking about whether it's perceived risk or perceived benefits. Maybe they think it doesn't talk to them, or it doesn't pertain to them, whether it's because they're too young, or whether culturally they think breast cancer is not going to affect them. Sometimes it's because of lack of knowledge.
Right.
Knowledge about breast cancer, or knowledge about the importance of getting screened, and sometimes it's barriers. So Hartford HealthCare Cancer Institute, along with their team of community outreach, decided to put together ways or come up with alternatives about how to overcome these barriers.
Right.
And one of the most effective and successful ways has been the Mammobus. Karen and the team will go out, and I've had the joy to work already with them, and it's fantastic the effort that they put into going out to the communities and driving this big bus where women can just step out of their house and be getting their mammogram, which is still today the best way of diagnosing and realizing the presence of the breast cancer.
It really is quite impressive. And you often hear about if there's a family history, if your mom has it, or if your grandmother has it, and you're a woman, you should be tested, or you're most likely to get breast cancer, or you're at higher risk.
Yeah.
With Beyonce's father being diagnosed, is Beyonce at risk? Is her children at risk as well? What happens when a male is diagnosed?
Male patients diagnosed with breast cancer who are male should always undergo genetic screening. You know, and so because it is relatively uncommon, and so what we want to do is make sure that there's no specific gene or mutation that is driving that gene, that tumor. You know, I think we've all heard that there's some genetic predispositions about breast cancer. There's specific genes, some of them called BRCA or BRCA. There's two types of them, and they both increase the likelihood of a patient getting breast cancer. And not breast cancer alone. There's other types of cancer, just such as ovarian cancer, prostate cancer in men, and both of them can raise those likelihoods. So, you know, now it's so important whenever a patient gets diagnosed with cancer to talk to them about their family history and to be aware that genetic testing might not only be appropriate for them for the sake of realizing whether a specific medication can be used in them, because now there is specific medications that have been approved by the FDA specifically for those patients who carry those mutations, but also for the rest of their family and their children.
And genetic counseling is really making a big play now. I mean, years ago you didn't hear about this. It really wasn't available, but now it is, and it's really making a big difference.
Huge. As a matter of fact, you know, here at Hartford HealthCare Cancer Institute, we're making a special effort to bring back those patients who before should have been screened genetically. Now all of a sudden we're realizing the importance of screening them, and we're retrospectively sending them to genetic testing. You know, we have a team of genetic counselors that help us out and meet with the patients and determine the need for this to happen. And I gotta say, it's been game changing, not only for the patients themselves, but also for family members.
Yeah, Dr. Menendez, we have a question from Sam. She writes, I am 28 years old. When should I get my first mammogram, and how often should I get one? Thanks, Sam, for asking the question.
Yeah, that's a really good question, Sam. So, breast cancer screening or mammograms are usually asked or recommended by the American Cancer Society after age 40. Now, as you and I were talking, and as a lot of people know, there are special situations or considerations where patients should start getting screened earlier than that.
Now, if, for instance, Sam had a family history, would that be considered she could be getting screened earlier?
Yes, exactly, Sam. So if, for instance, if it's a first-degree relative, meaning it's one of your siblings, your sisters, or your mother who was diagnosed with that specific cancer, whether it's breast cancer or, again, prostate cancer, ovarian cancer, maybe pancreatic cancer, it'd be important that you talk to your physician about it. But if they were diagnosed with breast cancer, what we would recommend is getting started with a screening mammogram 10 years before they were actually diagnosed. Meaning, if your mother or the relative that was diagnosed with that specific cancer was diagnosed at age 35, then you should have started at age 25.
And for women who have a strong family history or who are at higher risk, they would get the mammogram earlier. Would they also get an ultrasound, or, because I know women with dense breasts should have the ultrasound screening. What about women who are at high risk? Would they also get an ultrasound as well? Yeah,
so sometimes we would recommend ordering an ultrasound, especially if it's earlier in life. If their breasts tend to be a little bit dense. There is a question also whether MRI of the breast would also be beneficial for these patients, and it's really a matter of every single person and every single case is different. But in addition to the mammogram, in earlier or high-risk patients, we will recommend adding additional testing, not just the mammogram.
One of the biggest advancements so far in triple-negative breast cancer has been immunotherapy, recently approved to treat this. Talk to us about triple-negative breast cancer and immunotherapy and how that uses the body to attack that specific tumor.
Yeah, so that's actually a really good question, because that's really one of the areas where we've done some advance lately. Immunotherapy has been around for several years or decades. And unfortunately, up until now, breast cancer was one of the few diseases that didn't really benefit from the presence of immunotherapy. Triple-negative breast cancer has actually been, it's got a bad reputation because, sometimes you'll hear us talk about other types of breast cancer such as ER positive or HER2 positive. Those are cancers that have specific or good connotations to them. Now, all of a sudden, you have one that's called triple negative. It's got a negative connotation as it is, because what we're saying is it doesn't have the specific tumors or the specific markers that we're looking for, but we still don't know which one it is that it possesses. So when we're talking about triple negative, it's got the reputation of also being one of the most aggressive or difficult to treat because we don't have specific medications that are good for it. We treat it with just chemotherapy, and a lot of the time the cancer has a high risk of recurrence. And so all of a sudden everybody got super excited because there was a specific clinical trial, the InPassion 130, that actually showed that the addition of immunotherapy to a chemotherapy that is well known, has been used for years, and relatively well tolerated in our patients, would actually provide a benefit in how long the disease would be controlled for. And so we all got super excited about it. Now, the specific problem to that is now we have to make sure that the cancer actually possesses that target that immunotherapy is looking to encounter. And that's been sometimes a challenging part. Not all cancers, not all breast cancers will have the specific mutation.
Right. And you hear about immunotherapy. You also hear about precision genomics or precision medicine. What is the difference of the two? You've got the immunotherapy that uses the body's immune system to attack, and precision genomics or precision medicine is what you're attacking the cancer cell. Explain a little bit in detail, because I know those words are out there a lot and women may not really know the difference.
Yeah. So immunotherapy, again, is kind of what I was mentioning before. What we do is, cancer is thought to be the failure of your immune system at recognizing that there was an abnormal cell. Because we tend to create abnormal cells all the time, but the immune system is usually capable of encountering them, identifying them, and destroying them. Whenever cancer actually develops, which is just the accumulation of one specific cell that started multiplying and causing that mass, we say the immunotherapy failed at recognizing that it was there. And so what we have thought is, okay, what if we potentialize? What if we get a little bit of power to the immune system, and then all of a sudden the immune system is capable of doing what it was supposed to have done before. And so that's what the purpose of immunotherapy is. Unfortunately, that relies on the fact that the specific tumor cells need to be presented with a specific marker or have something called tumor mutational burden, which is abnormalities in the DNA and therefore the proteins that it usually expresses. We need to provide that so that the immune system recognizes it. Now you have precision genomic, which is becoming increasingly popular in all of this, and rightfully so, because that's been an alternative for treatment for a lot of the patients who up until now didn't really have any other alternatives. So precision genomics, what it does is it actually breaks down the DNA of the specific tumor cells. This is specific to each one of the tumors. So every single person is different. There's no two tumors that are alike. And so we run the DNA in that specific tumor cells, and we identify if there is one targetable mutation. A lot of the times we're able and lucky enough to recognize that there is a targetable mutation, but even in the setting of having a targetable mutation, we might not have a specific drug for that one. Sometimes we are lucky to have a specific one. And because these medications have been approved for other types of cancer, not just breast cancer, but have been approved for other breast cancers, a lot of the times they're used under clinical trials.
I definitely want to get into the medications, but Dr. Menendez, we're getting a lot of questions coming in, so we want to make sure that we get to all of the viewer questions. We have a question from Betsy. She asked, if I have dense breasts, should an ultrasound take the place of a mammogram? Thanks for the question, Betsy.
Yeah, that's a really good question, Betsy. And actually, it's created a little bit of controversy, that one, because then should we just get rid of the mammograms and just do an ultrasound or an MRI of the breast? And the answer so far has been no. Mammogram has been around and continues to be because it is still the best screening method that we have.
It's still the gold standard, right?
Absolutely. The American Cancer Society and all the other cancer guidelines still recommend mammogram as the gold standard, and the other ones are just additions of the testing. But no, the mammogram should not be replaced by the ultrasound or MRI.
All right, we have another question. Rebecca asks, what are the stages? What do they mean? And do you recommend getting a second opinion?
So that's a really good question, Rebecca, as well. Those are actually all good questions. So what happens for the staging? So the staging is just a grouping of 3 different findings in the tumor. Number 1 is the size of the tumor. The second one is whether there have been lymph nodes that have been taken or they are positive for cancer. So breast cancer likes to go to the lymph nodes, and that's one of the things that we tell our patients every single time when they're diagnosing themselves or they're checking their breasts themselves, which is something every single woman should be doing. The lymph nodes in the axilla are part of the breast still, and so it's important to recognize whether those are inflamed or increased in size. Now, the other thing is whether breast cancer has gone elsewhere. And breast cancer likes to go to the brain, likes to go to the bones, likes to go to the liver, and so that's the third component. After we've done some calculations with it, we're able to determine what stage it is. Breast cancer, because of the advances we've made with mammogram, goes between 0 and 4. Stage 0 being the earliest one where surgery is capable of curing the cancer, and stage 4 where cancer has unfortunately gone elsewhere, and then all of a sudden we're not able to cure it anymore. And it is important because that will allow us to determine whether surgery or radiation or chemotherapy or a combination of all of them would be indicated to treat your cancer.
Right.
Second opinions, and I'm just going to finish this question for Rebecca. Second opinions are always encouraged.
Yeah.
It is never wrong to say, I'd like somebody else, a fresh set of eyes, to look into this and help me and determine whether you think this would be adequate. And I think no physician should feel insulted by this.
Right.
As a matter of fact, what we do is just we actually
encourage that.
We encourage it and we facilitate it.
Yeah, dotting your I's and crossing your T's.
Exactly.
We have a question from Laura. Is there anything you need to do to prepare for your mammogram, and how long does a mammogram take? Thanks for that question, Laura.
Yeah, Laura, that's a good question again. You don't need to do anything in preparation for a mammogram. It usually takes about half an hour, depending on, not only how busy the people at the hospital can be, but also on how smoothly the process goes and how long it takes to set up. But once you're there, it usually is about half an hour.
Yeah, and then after, the radiologist will take a look at that, and then you'll get the results that same day.
Exactly. They'll tell you if there's an abnormality that needs to be further explored with an ultrasound or a brain or a breast MRI, or whether you're all set and then you should just come back later.
Yeah, it's nice to get those results the same day instead of having to wait, the 7 or 10 days
I agree.
to get those results back. Nicole asks, how often should you conduct self-checks?
We actually would recommend, Nicole, to conduct self-breast checks as often as possible. One of the things is with menstrual periods that tend to be some changes in the consistency, and sometimes some women might actually notice a little bulbs or a little masses or a little growth in their breasts, which are part of the regular hormonal cycle. So we would recommend getting them as often as possible. Now, not every single time you're in the shower, not every single time you're laying in bed, but as often as possible.
Okay. We have a follow-up question from Sam. She said, I had breast reduction surgery when I was 22 years old. I'm curious, does this put me at a greater risk of breast cancer?
So that's an interesting question and not something that can apply to everyone. Breast reduction, to our knowledge, does not increase the chances of breast cancer. It will usually, sometimes we'll use mastectomies to reduce the cancer risk if there's specific mutations, such as the BRCA1 that we were talking about. I wouldn't say breast reduction decreases the chances of the cancer coming back either, but I don't think that it modifies your chances or likelihood of the cancer coming.
And the opposite, what if a woman has breast enhancements? Is she at a greater risk, or does that change anything?
We have looked into this before because there was, breast enhancement or augmentation was and continues to be a fairly common procedure. There is no real data that says that implants actually increase the chance of breast cancer or the chance of you developing this disease, whether it's de novo or whether it increases your chances if you actually have a family history of breast cancer. There is no data that justifies that.
All right. Becky asks, if I had a mammogram that has previously shown cysts, does that increase my breast cancer risk? And could those cysts, follow-up question to Becky, could those cysts develop into breast cancer?
So the fact, Becky, that you were told before that you have cysts, and then all of a sudden that they want to keep getting mammograms or even ultrasound, that I think is the appropriate thing to do. I don't think that every cyst needs to be biopsied. I don't think that you need to do an MRI of the breast or a specific ultrasound every single time you find cysts. Most of the time we are able to tell whether structurally and anatomically whether these cysts are concerning or they have a totally benign appearance. And so at that point, what we would say is just you need to keep an eye in making sure that you repeat your mammograms and ultrasounds as recommended by your physician, and just making sure that that is not growing. The mere presence of a cyst in your previous ultrasound or in your breast will not have an increased risk of breast cancer.
And it's like in colon cancer, when you have polyps, sometimes those could turn cancerous. Is that the same for cysts in breast cancer?
Yeah, that's a tricky question, because then what happens if every single person that has a cyst develops the cancer? But I will say, not all breast cancers develop from cysts.
Right.
Some appear to be just de novo or just appear by themselves without the previous presence or exposure to cysts. So the cysts, I think, by themselves do not increase the chances of this developing into cancer.
Right. Okay, Rebecca asks, how quickly do I need to make a decision about breast cancer treatment if diagnosed?
Rebecca, I think she had actually asked already a question. So if you get diagnosed with breast cancer, it depends on how aggressive your tumor is behaving. There are specific types of breast cancer. You and I, Tina, were talking about triple negative. Then we also have some other types, whether it's ER positive, which stands for estrogen receptor positives, whether it's HER2, which is another specific mutations. And there are another types of breast cancers. There's another one that's really aggressive and really bothersome and painful to patients called inflammatory breast cancer. And those are the ones that we don't like to waste a lot of time on. So there's no specific right or wrong answer. It really all depends on the specifics of your tumor and how healthy you are, how comfortable you are, how many symptoms it's causing. But I wouldn't say you're okay to just walk away from this, take a hiatus, and then come back. I would say we'd have to treat it sooner rather than later.
And I think, Dr. Menendez, that's a good segue into the nurse navigators, because if you are diagnosed, that's when the nurse navigator plays such a critical role in guiding you through that process, so you don't have to do this alone.
Yes, absolutely. It's nurse navigators have been game-changing. And I wish I could say Hartford HealthCare Cancer Institute has been one of the few where it's happened, but it really hasn't. It has happened in a lot of places. And the presence of nurse navigators is fantastic. It is fantastic not only to the patients, but it's also fantastic for us as physicians, because we are decreasingly becoming less frustrated by the delays in the treatment, in the diagnostic workup that our patients are requiring. For instance, here at Hartford HealthCare, we have a specific breast cancer related nurse navigator who is absolutely fantastic. She's able to get the patients to get their diagnostic workup, their staging workup, their, if you need support, a specific device under their skin to get chemotherapy. She's absolutely fantastic. And she'll text us and say, hey, would you mind seeing this patient right now or tomorrow morning, first thing in the morning? And they have been game changing and really
It's a crucial support system.
They are fantastic,
Yeah,
yes.
you don't have to go it alone. We have a good question from Melissa. She's 37. Should she have a baseline mammogram?
So, again, what we said before is, Melissa, is when should women have their baseline mammogram? Still, the guidelines in the American Cancer Society recommends that women start their mammograms or baseline mammograms at age 40.
Yeah.
There has been some evidence or some theories that starting earlier would be appropriate, but we still don't have data that has shown that getting a mammogram and starting early on will improve your chances of the cancer ever coming back.
Right.
So unless there's a strong family history or a specific reason why a baseline mammogram should be obtained earlier, I would say age 40 is still what we would recommend.
Still what you would recommend. And it's good to have that baseline because then you know you have something to compare it to.
Exactly.
And you can see if there are any changes as you go on through each year.
Yes, exactly.
I want to talk about the Survivorship Program. I kind of want to cover all bases here. We're talking about prevention. I want to talk about the Survivorship Program at Hartford HealthCare and all that entails.
Yeah, so that's actually one of the reasons why me and a lot of my colleagues are so excited about breast cancer in general is, women who are now being diagnosed with breast cancer, even later stages, like the ones we were talking about, stage 3 or 4, even those that has gone elsewhere, a lot of the times we're able to keep them, if we're lucky, alive without major symptoms, alive for years, and so it is important to talk about survivorship in these patients, because breast cancer does not only impact the breast, it also impacts the mind, the soul, the emotional side, the psychological part. And so tendering and taking care of all of those issues is important. Also, breast cancer treatment, especially if you are given radiation therapy or chemotherapy, we are unfortunately having to deal with what's called secondary malignancies or side effects such as peripheral neuropathy, which is nerve damage in the sense of numbness or tingling of hands and feet. And so we're having to deal with all those side effects. And how to deal with them has been something that we just fairly recently started taking a look into, and we have done really, really good progress.
And I think symptom management is so important with the pharmacological interventions that you have, because that's critical in a woman going forward with breast cancer.
Yes, we have seen cases in which the peripheral neuropathy, the nerve damage, sometimes some other types of chemotherapy will cause heart damage, and this is a smaller percentage of the patients, but a lot of them will have some type of side effects, and some of these side effects can last for a little bit longer than we would like them to. And so determining how is it that we can cure cancer and at the same time minimize the side effects of the cancer and the treatment used to treat the cancer has been an important focus of research for many years in the cancer societies. We've done, and we've taken a look into the specific medicines that can be used to treat those peripheral neuropathies, and there have been people at Mayo Clinic and other big cancer institutes where they have looked into this. The one thing that Hartford HealthCare Cancer Institute has also done innovatively is integrative medicine. And I keep going back to the peripheral neuropathy. For now, there's 2 medicines that have been proven to be effective for it. Not all of them. We still don't have anything for the prevention of chemotherapy-induced peripheral neuropathy. And so at that point, we start saying, okay, what if we did massage therapy, or what if we use acupuncture, vibration therapy, and all these other treatment modalities that have been proven to be effective, maybe even to treat the symptom, but more importantly, the associated distress.
Right. I want to talk a little bit about Hartford HealthCare was the charter member of the Alliance with Memorial Sloan Kettering, which allows breast cancer patients and all cancer patients access to hundreds of clinical trials, and that they can be treated right here in Connecticut. They don't have to travel to New York or elsewhere to get that world-class care. What do you see in terms of on the horizon in terms of research in breast cancer?
Yeah, so that's one of the big benefits of Hartford HealthCare Cancer Institute is the fact that we have that alliance with Memorial Sloan Kettering, and not only are we able now because of it to provide access to very integral and very personalized medicine, but also to the access of these clinical trials that help us identify drugs that are usually not available to the public unless in this experimental setting, but a lot of them beneficial for them. Also, what has happened is Memorial Sloan Kettering is now helping Hartford HealthCare Cancer Institute provide or gain access to some of their research utensils or research trials and collaborations. We were talking about minority oncology. I recently had a very pleasant conversation with them about talking about them helping us develop some of the research ideas that are coming right here at Hartford HealthCare.
Lots to look forward to in terms of research there. Laura asked, who should I contact if I think I found a lump in my breast? My primary care physician or OBGYN? Thanks, Laura, for the question.
Yes, that is a question that I think a lot of people will be asking. And I would say either one of them would be appropriate. We tend to say primary care physicians would be the right people to go to. There is also some people who would say the OBGYN would be the appropriate person to go to. All of them have the ability and expertise to diagnose you and determine whether further workup is necessary.
Great question. And Lindsay asks, if someone has a history of breast cancer, are they eligible to receive genetic testing? Thanks, Lindsay, for the question.
Lindsay, that's a good question. And just like we were saying before, sometimes we're able to retrospectively send the patient back to genetic testing if we believe that she met requirements at that point. Meaning, if you were diagnosed at an earlier age, then you would be a candidate to receive genetic testing. If you have a strong family history, then you would be eligible to receive genetic testing. And it really all depends on the tumor characteristics, Lindsay, and the age at which you were diagnosed and your family history. Those are things that need to be taken into consideration.
And a little bit follow-up question from Lindsay, a little bit more about her background. If you have history of leukemia, are you prone to secondary cancer, such as breast cancer?
Yes. So patients who have had history of leukemia or lymphoma sometimes are at increased risk of having breast cancer. For instance, if you ever received radiation therapy to your chest when you were a kid before you started having your menstrual periods, or less than 14 years of age, I think is the cutoff for men who don't have menstrual period but still are at risk of having breast cancer, then those patients should get earlier screenings as well, and should include a MRI of their breast or chest in the case of men as a way of completing the screening for those. That does increase the risk of them having specific breast cancer.
And speaking of men, it looks like we have a question from a man. Nice to see this. Drew asks, can you talk about the misconceptions of men suffering from breast cancer? Thanks, Drew, for the question.
Drew, I'm happy that you asked that question. It is fantastic because, this is a huge taboo. A lot of men don't like to say they have breast cancer because then they think in a negative connotation that they have breasts. Truth of the matter is we all have breasts. We all have some breast tissue. And so we are therefore all at risk of developing the breast cancer, Drew. Breast cancer, like I said before, only 1% of all breast cancers is diagnosed in men. Now, because there are so few cases and we are unable really to put them all together in developing clinical trials specific for men are usually tried or treated as women would be, with the medications to block hormone receptors, to block or same chemotherapy regimens that are usually used for women. But it is important to break down the barriers. And as a matter of fact, I applaud Drew for asking that very important question.
And should men be doing self-breast examinations?
Absolutely. Absolutely. They should be, and it should be a lot easier for them because their breasts are smaller.
Right, are smaller. Drew has a follow-up question coming in right now. What are the different options for surgery, and how do you go about by determining the best option?
So the best option for treatment of the patient's breast cancer, regardless of whether it's a man or a woman, depends on the staging of it. If it's early stage, then sometimes surgery alone might be okay. Depends on the size and whether the lymph nodes that are part of the breast under the axilla are positive or not. It really will depend on the staging and the characteristics of the tumor. A lot of the times it will depend on the age and how functional or healthy a person is as well. But that is a discussion that we as physicians and we at Hartford HealthCare will always take with the patient, and in collaboration with the radiation oncology doctors, the breast surgeons, the medical oncologists, the nurse navigators, the genetic counselors. We always make sure that we talk amongst ourselves to determine what the best treatment option is.
Question about nerve damage. Angela asks, what can be done to prevent it?
That's a great question, and something that I have personally looked into. There is to date no pharmacological intervention that has been approved for the prevention of breast cancer or peripheral neuropathy or nerve damage related to the chemotherapy. Unfortunately, there is no medication that has had that luck. We have looked into the potential of using certain drugs or creams at trying to decrease the severity once it has already established itself, but unfortunately we do not have that specific medication to prevent.
What about lymphedema therapy after treatment? A lot of times you hear women going through lymphedema therapy. Can that help with nerve damage?
So nerve damage or lymphedema can actually sometimes make it a little bit worse because, lymphedema, if you think about it, is just fluid that's just stagnant there after the patient has had their lymph nodes removed.
Yeah.
That's an important thing that I like to clarify. So lymphedema, for those who don't know it, is after a patient has breast cancer surgery, and if there's indications to go and take away some of the lymph nodes in the axilla, then the patient is at increased risk of having swollen or increased size of girth of the arm because there's pooling of fluid outside of the vessels. And so that kind of like edema or just inflammation. And that just puts a lot of external pressure or compression on the nerves that can sometimes lead to worsening of that. So yeah, lymphedema can actually make things worse.
Interesting. Good clarification. Willow asks, does obesity or weight increase the chances of developing breast cancer? Thanks, Willow.
Yeah, thank you, Willow, for that question. Yes, breast cancer has actually been proven to be somewhat related to the weight. Estrogen, which is a hormone that all women produce, is usually stored in some adipose tissue or fatty tissue. We all have fatty tissue, no matter how skinny we are. The more weight we have on our bodies, the more fatty tissue we have, and the more areas for accumulation or reserves of that hormone can happen. And so breast cancer has an increased risk, a direct association with obesity and overweight. One of the things that we always ask our patients is to keep a healthy lifestyle. Not only avoiding smoking and keeping active, but trying to avoid or decrease the amount of fat that we accumulate in our bodies. The other thing is we've actually done studies where the risk of the cancer coming back after you've been diagnosed with cancer, of course, and then making sure that we keep our weight within nice limits or good appropriate limits, and we keep low accumulation of fat in our bodies, we are actually able to decrease the chances of the cancer coming back by up to 20%.
Wow.
Yes. So that is why it is important to keep a healthy lifestyle for these patients.
Absolutely. That's really across the board for all types of cancers. We have a question from Sam. She asked, does breast cancer, can it increase your chances of conceiving a baby?
Sam, that's a good question, actually. So breast cancer, if you are diagnosed with breast cancer while you are pregnant, there is no evidence that not becoming pregnant, and sometimes what patients think about terminating pregnancy, that actually has opposed or negative outcomes. Meaning if you get diagnosed with breast cancer while you are pregnant, then there is worse outcome if we don't carry that pregnancy out through terms. Now, if a woman who has not been pregnant or is not pregnant and is diagnosed, there is actually some data that says that patients who get diagnosed with breast cancer who become pregnant about 2 to 3 years after their breast cancer has been treated can actually have better outcomes opposed to those women. That is not to say that if you have breast cancer, you should be planning on getting pregnant to increase your chances. But we have seen those because we are increasingly seeing women of earlier ages who are being diagnosed with breast cancer, and it's important to clarify those. Women who get treated for breast cancer are not forbidden from becoming pregnant again.
Right, and we're seeing so many women without a family history being diagnosed with breast cancer. And there's no correlation, but other than perhaps some environmental factors.
Exactly. Environmental factors are big. They're really important, from nutrition, from chemical exposure, tobacco exposure, all of those issues are important to take into consideration.
Absolutely. And just one quick thought. I know you're brand new to Hartford HealthCare, just a few months, so we welcome you to the Hartford HealthCare family. And really developing a program, just kind of bringing it full circle to minority oncology. You have a whole staff of Spanish-speaking team and clinicians ready to help the underserved population of the Hispanic community. So I know you're going to be doing a lot of wonderful things, and you've already done such wonderful things so far in developing that program. But what else quickly can we expect?
Yeah, part of my desire and my dreams about joining this was to serve patients with breast cancer. Sure, I am Hispanic myself, and I have the ability to connect through language, emotionally and psychologically, to the Hispanic population. But in general, I am passionate about breast cancer and symptom management and survivorship as well. I think it is important having a team that speaks both languages, not only English, not only Spanish, but both of them, that greets you through the door and that places you in the room, and then you have the provider who comes in. But I think the most important thing about Hartford HealthCare Cancer Institute is the compassion that everybody has. I am surprised and I am astonished by the fact that every single member in our team, whether it's the person who greets you at the door, the valet parking person, whereas the surgeons, the medical oncologists, we are all eager to go above and beyond to treat and certify and justify the rightfulness treatment of our patients.
Dr. Menendez, thank you so much for joining us today, and we look forward to all the great work that you're going to do here at Hartford HealthCare for breast cancer patients, for all breast cancer patients, including Hispanic women. So thank you for joining us.
Oh, thank you.
We also want to thank T-Mobile for helping us connect to you out there today and all of your great questions. We appreciate it. Really, really tremendous questions. And want to say, make sure to come on down here to Blueback Square right here in West Hartford to the Pink Party. Preparations are well underway. You can probably hear them behind us. Everything kicks off, all the festivities kick off at 5 p.m. So once again, thanks for the great questions and for joining us. I'm Hartford HealthCare's Tina Verona. We hope to see you at the Pink Party.